Welcome everybody. I think we're going to have a very a good variety of speakers tonight. So we're all going to introduce ourselves as we go along. We're going to talk a little bit about our specialties, and then hopefully we can open it up to questions. That's the best part of these things. It's just to hear questions and answer those. But my name is Frank De La Rama. I am the clinical nurse specialist in oncology and genomics at the Palo Alto Medical Foundation. A lot of my work there is as a nurse navigator. So I meet with mostly prostate cancer patients at the time of diagnosis and helping them through the sea of appointments and trying to helping them make decisions and all of the healthcare decisions they need to think about. And I also do genetic counseling. And so there's a lot going on in genetics today, but as a genetic counselor with my patients, there's a lot of issues in ethics and legal and do I want to know and are these tests going to be helpful to me or not? And so I know Pam asked me to speak tonight just about, we're not really talking about just cancer tonight, but how do we handle these difficult conversations? I mean, as a nurse in oncology for many years, I've known so many families, and I've got the privilege of being at the bedside with many of them. And we have to have some of these difficult conversations, not just about grave diagnosis and cancer, but also, tough decisions. That's one thing that I don't know. You as caregivers or as patients, maybe that's something you struggle with. How to approach making tough decisions, or even a lot of my patients who are newly diagnosed with cancer, how do we share it with the family? So that's another thing that I'll chime in about tonight. But I remember the advice that a lot of my nursing professors gave me early on. I mean, it's nice to have a specialty where even in the first year that we were trying to be taught about communicating with patients, with all the different generations. And especially they try to give us some tips on how to address these tough issues. And so their advice to us, number one was to remember that I'm not alone in this. I'm a new nurse, but I can always get resources. As a caregiver, you want to think about that as well. Maybe it's not just me breaking the news. It's not just me who has to solve this problem. It's about getting the resources and learning how you can help and when you want to recruit help. The second most important thing is just to approach these conversations without fear. And one of the most important things about that is to listen. We probably don't listen as much as we should in these conversations, or sometimes it takes experience on how to know when to say more or too little, but it's always important just to think. You're probably saying too much anyway. So just tip number 2 is always to listen. They always told us to be gently honest. And so whenever we're talking about sensitive issues, they didn't want us to use jargon and initials and acronyms. They just wanted us to tell the truth, talk about the situation at hand. But the most important thing in communicating these difficult conversations is to really be present. And so being present is just paying attention to who you're talking with. That's the example of good communication. I know examples of bad communication because I've heard patients, because the thing about communication, most of it is nonverbal. So it's kind of what you're doing, the tone that you're using, and just a little bit of that is words. Because I remember one of my patients who was newly diagnosed, the reason he didn't like this particular doctor, he told me, well, he checked his watch 3 times during my visit. And even though the doctor had a lot of good information, he wasn't present. And so we got that feedback from our patients, and we shared that with a lot of the providers there, and I don't even wear a watch anymore. So that just is a reminder to me every time I hear about that, is just to be present. And so those were the things early on as a nurse that I dealt with, and the other things that I help patients with is just making decisions. And so I don't know, everybody is faced with making tough healthcare decisions, and there's no correct answer. But I usually gather some advice from the business world or from other places where they have ways of making, it's called shared decision making. And so That's another great resource in just how to approach these problems. We're not, if I was working with my mother who had breast cancer, even as a nurse, I don't want to tell her what to do. The goal in shared decision making is to help her come to the decision on her choices, because she's the one who's going to own that decision. So there's a lot of work that we do in prostate cancer, for example, where they have too many choices. And the national guidelines say you could do treatment number 1, treatment number 2, or treatment number 3. It doesn't matter what you pick. So as a nurse navigator in shared decision making, we'll try to boil it down to the components. Look at each aspect of this treatment, this side effect, or how's it going to impact my quality of life, and so on. And so there's ways, and there's a lot of resources on the internet that I can share with you where you can have these exercises in shared decision making. That actually helped me with dealing with my own personal healthcare decisions. So it kind of bleeds off into your personal life, even as a healthcare provider. But hopefully I look forward to hearing more from these people up here, and I look forward to hearing more from you guys. And at the end of the summer, I'd be happy to take questions about just having these difficult conversations, and just strategies on how to make those easier.
That was wonderful. So I'm Erica Weirick, and I'm a primary care provider at Palo Alto Medical at the Los Altos Center. How many of you here are here as care providers? Just raise your hand. Okay, and how many are here as patients? And how many are just here just to kind of gain information? So just to get a sense of what angle to sort of share from. What's interesting about the role, I think, of primary care providers is that it's changed a lot in diagnosing major illness, and actually it's been kind of a blessing that diagnosis has changed to the point where we're often now very involved in the initial giving of diagnoses. And one example is in breast cancer. In the olden days, it used to be that a patient would go for a mammogram, and then you might get called to order a follow-up diagnostic or compression, and then you might not hear anything, and you might 4 or 5 months later find out that your patient is midway through chemotherapy as a primary care provider, and it would be kind of shocking. But things have changed, and now oftentimes we're ordering a mammogram and then even sometimes a biopsy, and we're often getting the tissue diagnosis or the information for diabetes or the lab tests or major illness information, right away. And so we're communicating that. And the thing that's so incredibly wonderful about that is that it gives us a chance as primary providers to walk that path with patients. And I think that most people who are in the role of sort of primary caregiving from any standpoint, from Frank's standpoint or nursing standpoint or even a chaplain standpoint, is really that's what we want to do. We want to have the privilege of sharing that path and of being of some service. And it's really been the greatest privilege of my life to take that path with some people, and even though it's also been exquisitely painful at times, it's just been such a privilege. So in that light, I think one of the things that happens is that we look at what a patient might need and how we can fill in the gaps, because patients tend to have a specialist and a lot of other providers. And I've noticed recently that one of the things that can really work well for patients, and it may be an endocrinologist who does this, it may be an oncologist, it may be a social worker or a nurse, is that somebody takes the lead in communicating with that patient through that illness. It sort of naturally happens that there seems to be a point person, and actually it can even change sometimes throughout the course of the illness who that is, depending on what stage of treatment or what's going on. And what's been an amazing sort of learning experience for me in playing that role is that, as Frank kind of mentioned, nothing that I learned in medical school really prepared me for how to do that effectively or how to be in that role and be effective. And what's really helped to be in that role is to put myself in the position of the patient and ask, what is it that I would want in this moment? What is it that I would need in this moment? And actually have a story just to highlight that, which is been really an incredibly helpful learning experience for me, which is that I had a gentleman come in who had a prostate cancer, which was in really a stage where treatment was really unclear. So it was a small area that was involved, and it was a cancer that had not spread. And so he was offered the option of surgery or the option of watchful waiting. And so he got the options from the oncologist, made an appointment with me, and came in to talk with me about what he should do and what he should choose. And I had to take a few minutes and just sit and think, because I didn't know immediately how I could approach answering that for him. And in a few minutes of sort of thinking, I realized really the only tool I had was to step into his shoes. And so as best I could, I stepped into his shoes and thought, what would I need in this moment? And what I realized that I would have needed was a little more information about what watchful waiting would be like and what surgery would be like. So what I did was I asked Frank to become involved, and I asked if he could help with a survivorship plan so that we could see what watchful waiting would be like. And then we called the surgeon as well, and we asked one more surgeon too for an opinion about what surgery would be like and what would be involved. And by laying all of that information out, he was able to touch base with how he felt about, how he might, he didn't even really know how he would feel, but how he might feel or what his initial feeling would be in waiting and trying the watchful waiting approach. And we realized in that first discussion that he may find that after waiting one cycle and doing one test, that was not for him, and then he could change his mind. And so that whole conversation was really illuminating for me in terms of what it really takes to walk the path a little bit. You're never really walking the path, but to really provide a little bit of support in that setting. And it was really an incredible learning experience. And what Frank offered in terms of a survivorship plan was extraordinarily helpful. And as he mentioned, you're not alone, you have a team. And I like to sort of imagine that to be true for the patient too, that the patient has a team. And as a primary provider, as a social worker, as a person in the role of generalist, one of the things we can do is to pull heads together and try to look at the whole person and help remind the team about who the whole person is, and help to hold that spot as we go along the journey of treatment and finding out what's down the road. And then I think also I would feel in any health situation like I wouldn't want to be abandoned. So I think the other thing that we can do as providers is to be there and to call and to ask. And sometimes it's really hard. Sometimes it's hard to face a diagnosis. There's actually a study that came out not long ago in Journal of American Medical Association that showed that providers who tell the truth are not actually liked as much as providers who don't by their patients. And that was a little bit of a shocking, did you see that article? It was a little bit of a shocking realization that the truth doesn't actually always make you liked. But I think we all know our responsibility to the truth, and that isn't really what matters to people as much as the idea that somebody's there to ask. One other example I thought I'd share is I had a patient who had a pretty severe neurodegenerative disease. And she had the opportunity to see an uber specialist in the field who was a specialist in just her disease. And she went to see him, and she came back with a nice analysis of the issue that mentioned that he didn't think that she should be on the antidepressant she was on because it didn't actually have any benefit to the disease. And the patient had read this. She was aware of this. And so she said, I think we better stop this medication. And I actually didn't know, reading the note either, whether the doctor happened to think that that medication was actually damaging to her health with that diagnosis, or whether it was just that it wouldn't contribute. And I was able to review the note, just being in that position of primary provider, much more easily than the patient could have tried to call and ask this uber specialist, what did he mean? Could he clarify? I was able to just look back and see what the original plan had been with that medication, and then quickly email that provider and say, is this going to hurt, or can she stay on it? It was really for this. And he was able to say, oh, I didn't realize it was for that. Yes, you could stay on it. It's not going to harm. And so just to be looking at the whole person and to be kind of shoring up the loose ends that are just too much when you're dealing with a major transformative experience. And, I say that in a very respectful way, because I think that that illness, while no one would wish any kind of illness on anyone, I think that the kind of internal transformation sometimes is an incredible gift. And I think that's the other shared learning that is such an amazing privilege to work with patients who are going through that kind of transition, that kind of learning in their life. So if you have questions about those opportunities, and the experiences and thoughts and your own experiences, and if I can reflect on, the sort of role of the generalist in the care team, particularly on that, I'd be really happy to do that tonight. I think that was about it. Yeah.
So when my mom was first diagnosed with breast cancer, I was 15, and I remember it was over Christmas break, and she was taking everyone individually and telling them about the diagnosis. And I remember thinking it was kind of like the flu. Oh, I just had no concept of what breast cancer or any kind of cancer was. And I know from working at Breast Cancer Connections a few years ago, now there's actually a whole section on how to talk to your children about your diagnosis. So things have come a really long way since 91, 92. When she was re-diagnosed in 2002 with metastatic breast cancer in her liver, I was living on the East Coast, and without even actually talking to her, I packed up and moved all the way back across the country, and decided to go on this journey with her, really without ever discussing it with her. Our communication back then was very different. She actually did her medical fellowship at Stanford. She was a very driven woman. My dad pretty much raised me because she was working so many long hours. And then I originally came from a business background. So having somebody who was very medically trained and very business oriented try to communicate was kind of hilarious, actually, or you have no idea how to communicate to each other. But in 2002, we began because I took the role of the informal or family caregiver, the primary role of that, not knowing that there was actually a title or a name or anything, just we were going to go together and to the doctor once a week for a while, and then by the time she passed away 8 years later, it was about 4 times a week. And I don't know if you've heard this analogy. I always think about this with caregiving, is if you put a frog in water on the stove and it's cold and you slowly crank up the heat, the frog just hangs out and takes a bubble bath and until the end comes. But if you take a frog and you put it in boiling water, it's going to jump out. And to me, that kind of really illustrates what caregiving was like, especially over this 8-year period, is it just gradually got hotter and hotter and hotter until all of a sudden, at the end, I went, what just happened? What just happened to me? What just happened to this 8 years of my life? When I decided to go back to graduate school for health education and nutrition, it actually was originally to help people going through cancer treatments be able, like you were saying, treat the whole person and really look at alternative ways to heal, complementary ways, all those good things. Look at mind, body, not just body. And my mom passed away over Christmas break after the first quarter I was in graduate school. And so my focus actually then turned to caregiver health. And so I did my whole thesis in it, and you will probably not be surprised to know that the majority of research done is not done in the US for caregivers. It's done in Australia or the UK, but the US is really not very far along on researching what happens to people when they're caregiving, health-wise, mind, body, spirit, any of it. So from the beginning, when we started the journey together and our communication was like two aliens talking to each other, we actually ended up at a point of deep, deep connection. And it wasn't easy, and it was, let me say it wasn't easy. There were so many challenges with it. But what ended up happening about 2007 is we decided to learn more about ourselves individually, and through that, we were able to learn a lot more about how to communicate with each other. So I do have a couple handouts. I don't know if anyone grabbed them, but I wrote down some key points, and then I wrote down some resources as well, if you're interested, about things that helped us get to a point where we really could have the tough discussions. And it wasn't just tough discussions about the diagnosis or the cancer or what was going on, but it was also about what was going on for me as a caregiver. I noticed a lot of times my needs were really put aside. And it was justified because the focus needed to be on her getting what she needed. However, if you look at the big picture of things, how can you really care for somebody else if your own well is dry, essentially? You need to take care of yourself so you can almost overflow and take care of others. So a lot of my focus and research was to figure out how that can happen in the medical world, is kind of put the spotlight on the caregiver as well as the patient. But just a couple key points that I found really helped us is separating the situation from the person. So it doesn't matter if you're raising kids, you're caregiving for your children, or if it's heart disease or cancer, whatever it is, separating that from the person. So in other words, we would have these talks that we would say, I really hate this cancer. I really don't like this, and I feel guilty for not liking having to drive you to the doctor the 4th time this week. But it would open the conversation. I wasn't saying, you know what, Mom, I really don't like you. I really don't like the fact that I have to sacrifice my time to take you to the doctor. It was, I don't like this disease. And it would open a conversation, and she would say, I really don't like this either. And it's terrible. And if you want, I can take the train. That was my mom. These are 2 of my mom's best friends. Yes, they will know. My mother was very stubborn. And actually, that was another conversation. She would want to take the train to the doctor. She'd want to walk a mile to go volunteer. And we'd have this, Mom, I know you're capable to do this. However, maybe after having chemo, you shouldn't walk 2 miles. So it would open the conversation to really separate the person from the situation. And again, the knowing thyself and knowing the communication style. Is anyone here familiar with Ayurvedic type medicine? So Deepak Chopra, that's his style of medicine. And in Ayurvedic, there's basically 3 different types of mind-body combinations. And they're all based on nature's natural cycles. So there's Vata, which is space and air. There's Pitta, which is fire. And there's Kapha, which is earth and water. And so when my mom and I actually got the privilege to go down to the Chopra Center in Carlsbad. And we learned that she was a Vata and I was a Pitta. That's our natural constitute. So basically, her air would blow my fire everywhere, and my fire would cause her air to go out of control. And it's a different way of looking at things, but once we kind of had that image in our head, we go, oh, no wonder we're driving each other nuts while we're traveling together. It's not just a mother-daughter thing. Other things one resource I put on here is the Enneagram, learning your personality type there. There's just so many different ways to figure out better ways to communicate. There's also a great book, Powerful Non-Defensive Communication, and it really has great tips on how to respond instead of reacting. As probably a lot of you know, chemotherapy affects brain function a lot of times, and so my mom would do things and say things that, again, weren't her. It was the treatment, it was the illness. But for me, what I learned to do is just respond, is to take a couple deep breaths, relax, and respond, and not react. Because who would I be reacting to? Not my mom. It was the treatment I was reacting to. So I really learned how to respond. And I also think throughout this, there's kind of an emotional continuum. So there's never any good or bad emotions. A few of the research studies that I looked at would really highlight the fact that caregivers would have this guilt and this anger and this fear and feel badly about it. But in reality, there's no bad emotion. especially if you're in the state of responding to those emotions. Why am I angry? You know, what is going on there? Another way I really found to deal with these emotions, because I'm sure most of you know there are a lot of emotions that come up with caregiving, is to act almost like as a witness to myself. And actually Chopra has this technique of journaling. Instead of journaling, you know, this was my day, this is what I did, doing it in third person. So Amy got up on the wrong side of the bed and was grumpy all day, you know, so it kind of puts you in that witnessing state of mind. And I found, especially sitting in the doctor's office, I mean, we spent 20 hours a week there, sitting in that doctor's office. When things would rise up, if I could take myself out of the situation and witness it, it just diffused the situation, and then I could be present. And I know Frank mentioned that a couple times, is the ability to be in the present moment, whether it's good, bad, or ugly, you're in the present moment, and you're able to feel everything that's going on. So that helped a lot. And another technique that I found useful from one of my Qigong instructors is the idea that boundaries, if you have good boundaries and you're taking care of yourself, the barriers to emotions can really come down. For me, it was very frightening to talk to my mom about death and dying and illness and life and love. And it was just hard because we never tapped into that. And so to be able to tap into that, I didn't do it very successfully for a long time, but I did learn how to have boundaries, so I was taking care of myself. So those barriers could really come down. Does that resonate? Does that make sense? No. So being able to give myself time to, say, take a hike or to meditate or to go on a trip allowed me the time to get enough self-care in that I felt strong enough to deal with emotions that came up. So those barriers between her and I could really dissipate. But it's a hard thing to do, and I'll readily admit that, and granted I was in my late 20s when the whole thing started, but I used 2-buck chuck as a crutch for a long time, you know? and I had to shift that. So the last thing I really want to point out is there have been a few research, one of the research studies I used a lot to fuel my thesis is at a university at Calgary, and it talks about, it's called the modified self, and it talks about the self-identity shifts that happen when people are caregiving. So, you know, who I was at the beginning of the journey is so much different than who I am now. And to be able to just recognize that the identity, the ego, the kind of the center point that we all look to as self-referral does shift in a caregiving role. Just to be aware of that and to observe it. So, yeah, I think that's it. But definitely grab a hand. I have a couple books if you're interested on there, listed on there. So.
Thank you.
Yeah.
Well, it sounds like we're in the midst of the breathing, building.
Building, breathing. So I told you about.
I'm so glad you warned us. So, yeah,
It sounds like we're about to take off.
it does.
We're really not.
Yeah. I'm Lori Klein. I am the oncology chaplain at Stanford Hospital. But what I'm going to talk about tonight really applies not only in any kind of caregiving situation, but really any human situation, so very broad. And what Amy was focusing on were communication skills and how that relates to self-knowledge and self-care. And so I'm going to do, in a way, the very closely related mirror to that, which is developing listening skills and how that relates to self-care. And with the goal of building an emotionally open and authentic relationship. So I'm going to start by telling a truth that I think might be surprising or not very pleasant for most people to hear, and that is that all of us, and that includes all of us in this room, at least some of the time are poor listeners. And many of us are often poor listeners. And there are reasons for that. So first I want to talk about why why we don't listen well. When you're in conversation with somebody, obviously it's interactive. So somebody starts talking to you and you are almost immediately thinking about your response, or you're thinking about a story this reminds you of. And what happens then is you stop fully attending to what the person is saying, and instead you're composing your reply. And you might be continuing to edit your reply, but you're really focusing more on yourself than on the other person. And so one general skill to practice is to try to quiet that voice. It's a very natural voice, but to trust that if you are quiet and listen, and maybe even have an agreement with the person, if you can get into a relationship like this, where there can be even a little bit of silence after they stop speaking, that in that silence you can compose your reply, and then you have fully attended to them. A lot of us feel, because many people are poor listeners, almost all of us walk around feeling like nobody listens to us, because it's true. and so we mostly walk around feeling in a place of deficiency, because we feel somewhat invisible. And so we're always looking for our opportunity to be listened to and our opportunity to be visible, except that then there's a vicious cycle, of course, because then we've just added to the deficit of the person who's been speaking, because we're not listening to them, because we're waiting for us to be visible. And so similarly to what I said with the first one, is to recognize that we all deserve to be visible, and that what you can do is to soothe yourself around that need to be visible, and be aware that that's coming up. I mean, it is sad that most of us go through a lot of our day without people listening to us very well. And we really treasure the moments when people do listen to us well. But if you're in every conversation, every moment is a new moment. Every conversation is a new possibility to start, kind of the virtuous cycle of listening well. And so if you're in a conversation and you're feeling yourself being invisible, a first step can be to soothe yourself a little bit, that you know why you have this deficit. It doesn't necessarily all have to do with the person in front of you. Maybe the person in front of you is a relatively good listener, but the 15 people you've talked to in the last 5 hours haven't listened to you at all. So to really try to be in this conversation. When we are in a situation of caregiving, or even we're not necessarily in a situation of caregiving, but somebody who we care about is ill, we have a desire to do something. We want to make it better. We don't want them to be ill. And so we fail to realize that sometimes the best thing we can do is listen. And so instead, we give advice, often unwanted advice, often advice that is not at all appropriate for that person, or maybe we repeat something that has been emotionally or spiritually useful for us, but is not necessarily at all useful for them. So to give you an example, there's a saying that a lot of people use, God never gives you more than you can handle. And for some people, that's a very useful saying. It's a very useful saying for them. And I've talked with a lot of people who have been seriously ill, and I've had some of them tell me that they've wanted to become physically violent. If one more person says that to them, and I'm seeing a lot of nodding heads. So just to realize that if somebody says that to me, if somebody who is struggling with illness says that to me, God never gives you more than you can handle, I recognize that that's a useful statement to them, and I'll affirm them. But we don't say that to somebody else. And so it's about being alive and open to the wonder of what's going to come out of the other person's mouth, instead of being so enamored with what's going to come out of our mouth next. Another thing that comes up in the context of illness is Amy was talking about the journey that she and her mother went on to get to a point where they can talk about things like dying. And we can become so filled with grief or fear or anger at the universe when these topics come up, and we're not able to tolerate our own discomfort, and so out of our own discomfort we will shut somebody else up. So to give you a quick example of that, there was one time I walked into a patient's room and their family member was sitting at the bedside, and I introduced myself to the patient and I said, "Hello, I'm Lori, I'm the chaplain," and he said, "Oh, I'm so glad you're here. I've been wanting to talk to somebody. I'm afraid that I'm dying." And the family member said, "Oh, don't talk about that." And I know that they said that completely out of love, out of their own grief and anxiety about their loved one dying. But what they were doing was not allowing their loved one to talk about what was really on their heart in the moment. And so, what I did in that situation was I turned my body just a little bit so that I was really more facing the patient than the family member, and I said, do you want to talk about it? And the patient said yes. And then the family member had a choice. They could stay or go. And in that case, the family member left the room. It would have been my fondest wish if they would have stayed, but they couldn't be in the room then. And then everybody got what they needed in the moment. So if we're able to tolerate our own discomfort, if we're able to soothe ourselves about the ways in which we go through our lives not being listened to well enough, if we're able to be still and listen, what are some techniques that we can use to listen well? First, I want to use the metaphor of an iceberg. So often when I start talking with somebody, I feel like all they're going to show me is the tip of their iceberg. Why would they show me more? Their experience is nobody listens to them, or very few people do. So they're going to show me just the tip of that iceberg. So an example might be you're talking to somebody who you care about, who's, let's say, somebody who's ill, and they say, "I've had a difficult day." So some responses that are really common to that are, "Oh, I'm sure you have," or, "Oh, yes, it must be difficult," or, "Oh, you've had a difficult day. Let me tell you about my difficult day," right? All of these are very common responses. What if instead you were to say, "Really, so tell me about one part of it that was particularly difficult for you." In my experience, that if you do that, first of all, you've let the person know, "I heard you." You're not turning the focus onto yourself. And you're helping them to go a little bit more deeply into their story. And then what happens is they'll tell you something more specific about what was difficult. And you find yourself, you're going down the iceberg. So then how do you get even deeper into the iceberg? So now they haven't just given you a one-liner about their day. They trust you a little more. They're telling you a little bit about their day. And you're hearing some emotion in their voice. And so you can say to them, "Oh, that sounds, not you must be sad," because we don't want to tell people what they must be feeling, but you sound sad as you're telling me this. Are you feeling sad? And I'll do this sometimes, and I would say at least half the time I'm wrong. I picked the wrong emotion. So they won't say, "No, I'm not sad, I'm really angry. I'm angry about," and then they'll tell me what they're angry about. And it doesn't matter. It doesn't matter if I'm wrong. Again, I've really let them know that I'm listening, I'm paying attention, not just to their words, but to the feelings behind and underneath their words. And if I'm wrong about what the emotion is, they'll tell me what the right emotion is. And then we'll be talking about the emotion. And from there, it just branches into, really what's going on, into deeper and deeper places. And what I would say is that for for you as the listener, for us as the listener, there's an immediate benefit to doing this. Your conversations become more interesting. You learn surprising things about people. You learn about people's histories in ways you haven't before. If you're not rushing to tell your own story, you really start to hear other people's stories. And of course, there might be times if you feel that you've gotten so good at this, and then you really are invisible. Now everybody's so hungry to tell you their story, you don't have the opportunity to tell your own story. You know, there are ways to say, I'd really like to talk about something that's going on for me, and hope that you'll get that same consideration in return. But to sort of really be clear and recognize when you want to help create more intimacy with somebody by really attending to them. The other metaphor that I want to talk about is the metaphor of the valley. So sometimes in the middle of illness, people get obviously upset, sad, and you talk to them and it feels like they're sitting in the depths of a valley. It's very difficult for any of us to tolerate that, and I include myself, and I've been a chaplain now for more than 6 years. When I am talking with somebody and they start expressing how sad they are or how discouraged they're feeling, I can feel all the messages in my head. I need to cheer them up. I need to make them feel better. I need to make them feel better now. You know, not in 5 minutes. I need to do whatever I can to do that. And I have to, then I am actually, in those cases, sometimes I'm not attending as well because I'm telling myself to have faith and keep being quiet. Because when somebody is sitting at the bottom of that valley, almost always one of the things that they're feeling is alone there. And if we can actually convince them that we're willing to sit there with them, we're willing to sit and witness them down in that valley, then we will let them know that they're not alone. And that will help to bring them up. You know, that without us directly saying, oh, it's not so bad, or it will get better, or let me tell you a joke to help you feel better, or, you know, any of the things that we might out of our love for them do to help make them feel better. By actually being willing to be with them down there, that is what will make them help them feel better. There's a lot of talk now about positive thinking. I'm very much in favor of positive thinking, except when it becomes a straitjacket, except when positive thinking becomes mandatory and the only way of being. And something that is used to really silence someone from authentic expression. And so, you know, one of the things I talk with people about is that it can be important sometimes to give yourself a misery date, or your loved one a misery date, and just, you know, allow yourself to feel miserable and have somebody be able to witness you feeling miserable and kind of get some of that out. And for a lot of us, if we're able to be in that place, in that valley, then our resilience will come back. It will come back up. So there are particular kinds of conversations that happen at the end of life. That is a whole topic in and of itself, so I don't want to go very deeply into it. Any of these skills that I've talked to you about, and these metaphors are very useful for an end-of-life conversations. And what I mean by end-of-life conversations are the kinds of conversations that people feel they want to have in order to heal relationships. And so some of the things that people are trying to get to at end of life are forgive me for, you know, fill in the blank. I want to forgive you for, you know, something that's gone awry. I love you. I'm grateful. And sometimes when people say that they feel like they want to talk about dying, they're actually trying to have some of those kinds of conversations. And so my invitation is, even if you feel very strongly that the person they're just in a particular mood, they're having a bad day, they're not really dying, maybe you're even correct, maybe they're not really dying. These are incredibly precious conversations to have, the forgiveness conversations and the gratitude conversations and the conversations about love. We should all have these conversations every week, but we don't. And so sometimes being willing to tolerate the extreme discomfort that prevents us sometimes from having these end-of-life conversations, if we can tolerate that discomfort, then it can bring us into very much deeper intimacy with people in our ongoing relationships with people that we love.